Good morning. This is the House Appropriations Committee. It is Thursday, January 8th, 2026, and we are continuing to talk about lots of different things. This morning, we're going to talk about the Rural Health Transformation Grant. The state was awarded $195 million a year for 5 years, and it's kind of a big deal, as Woody would say. So we're looking forward to hearing about that. So we have Jill from the Agency of Human Services and
Tracy O'Connell.
Okay, so if you both want to introduce yourselves and take it away, that would be great.
Sure. I'm Jill Mazza-Olson. I am the new Medicaid and Health Systems Director with the Agency of Human Services. So I have responsibilities for the Medicaid program and also for healthcare reform.
And for the record, I am Tracy O'Connell, and I'm the Chief Financial Officer with the Agency of Human Services.
Is this the first time that you took the year?
This is the first time I've ever testified other than advocacy speed dating. So,
Okay.
yes.
So today we're going to practice introducing ourselves. We haven't had to do that for a while. So Dave.
Good to see you, Jeff. Tracy, good to see you again, too.
I'm John Fitzpatrick from the town of Burke, 10 towns in the Essex Caledonia district.
Mike Nigro, I represent Bennington Appellate.
Tom Stevens from Waterbury, representing Washington Chittenden, which includes Bolton, Huntington, and Buell's Court.
Artie Phelps from Linden, representing Linden, Sutton, Sheffield, Wheelock, and Newark.
Robin Scheid from Middlebury.
Tiff Bloomley from the south end of Burlington.
Trevor Squirrel, Underhill, and Jericho.
Wayne LaRush, Highgate, Franklin, Berkshire, and Richford.
Hi, I'm Mike Murphy.
Southerner.
I represent the Wingwood Ford district of Highgate, Douglas.
Lynn Dickinson, I represent St. Albans Town.
Good.
Well, thank you so much.
Thank you. Okay.
So I think we're going to tag team a little bit is our plan. I think I will probably lead us through, but I really wanted to make sure Tracy was here, especially because a lot of the mechanics of things are new to me. So I wanted to make sure we could get to your questions. I've testified on this a few times, and I can tell you it's very hard to get through all 40 projects. And I also
There are 30.
it's kind of 40 when you add a few things in, and I don't have full subject matter expertise, as you can imagine, on every single project. So I'm not going to attempt that. But I will try to give you an overview so you have a feel for sort of the direction that we're heading in. And want to share, this is in my slides, that we do have a dedicated website for the Rural Health Transformation Fund, and it does include it includes our application, an overall summary, but honestly, I made a list for the list people. And so it's a spreadsheet of every single project with a short description. So I actually think if you're trying to understand what's in here, this is the most helpful document if you're interested in detail, but not 65 pages of application.
Great. And so that's on your website?
On our website, yes. And there's a link in our slides.
Okay. Oh, there is.
Yes. Yeah. I just wanted to share that with you.
Post those projects on the website. Okay.
Sure, great. I also should just say, I did share this with the committee. I have a hard stop at 10 because I'm supposed to be presenting to others at 10:15, and I have to make a transition to another building. So hopefully we can get through it all. So let me start with the first slide. So I think as you know, this is an opportunity from CMS, Centers for Medicare and Medicaid Services, to help states modernize their healthcare systems, their rural healthcare system. So it's really meant to be aimed at rural areas of states. There were the notice of funding opportunity came out on September 15th, and it included a series of sort of directions that CMS wanted to take us, along with some scoring criteria for essentially things that already exist, rural metrics, numbers of providers in Vermont, the size of our state, policies that we might or might not have in place, and then scoring that was impacted by our application. So the first $100 million, as we understood it, was going to go to every state, was going to get $100 million per year. The question was what would happen to an opportunity for the second $100 million. And so the rural metrics, the policies in place, things we could not change, were part of the scoring. And we knew we weren't going to score highly on those. We could score ourselves. And so to me, the size of the award reflects the strength of the application. We did well, and the only metric we had to do well on was the application itself. So to me, it says that we had a credible application. There is a lot of work left to do on implementation. So we're getting lots of questions about exactly how are we going to do this? How will everything look? We are working on building all of that out. This was a really fast moving process.
Yes. And so who did you collaborate with and bring in and talk to when you were
Yes.
putting this together?
I'm going to get there.
Okay.
Yeah. Yes.
I don't want to get ahead.
That's okay. It's a great question. And I anticipated it. So let me keep going.
Okay.
Just in terms of where we are in the timeline. So we submitted our application. We had a little back and forth with CMS right around the holidays around some questions that they had. And in that back and forth, it became clear that one of our proposals was not going to be allowable, which was a proposal to build workforce housing. They really just don't want us to do a lot of capital investment. They only are supporting minor renovations. So it just is a limit. It's really too bad. It was a really cool idea. And then we got our notice of award on the 29th of December. So this was really fa la 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 holiday season for us. And then we have a budget due back to them on January 30th.
Did you do a budget in the original application?
Yes, new budget because new number, 200 million. Now we have to have a 195. Yeah, it shouldn't be too hard.
Hard to revise it.
No, it's not. Some states have a much bigger adjustment to make than we did. Yeah. And then we will hear, they have 30 days to let us know if they have further questions or concerns. So I think it's going to be a while before we have everything fully finalized. Let's see,
Tom.
over the next question.
Just a
Yeah.
quick question in the, can you go back one slide, please? And so just in improving access, quality, and sustainability through infrastructure, workforce, and care, where does affordability play? Was that ever part of the
Yes.
application or the process?
Yes.
Because it seemed to be a very important word especially considering that the federal government has stopped subsidizing people's affordable care.
Yeah.
And so I'm very focused on how we use that word, and I don't even see it here.
Yeah. So it's an important word, and I totally agree with you. I think what's important to understand is we can't use these dollars for the purpose of the premiums, for the purpose of state match. We can't use it for those things. It is not allowable for those purposes. So this is really about system redesign, and where affordability comes in is not direct to individuals, but more about right care, right place, right setting,
And so
and investments to make that happen.
no, I appreciate that.
Yeah.
But I just want to make clear, accessibility doesn't matter if you can't get in the building.
Yes, absolutely. Okay. Let me, see, we talked about the award, the amount, and I think, and I didn't say this, but we are probably one of the, probably third highest per capita, we think, behind Wyoming and Alaska. And we are the second highest in New England. So again, I think it was CMS viewed it as a strong application that met their requirements, and we were really trying to meet our own goals. I may actually do a different order a little bit. No, I'll keep going this way. So some of the things to know, I think I've said some of these, but I wanted to make sure some of these things were clear. So we had areas of focus. So this is not our entire healthcare plan. This is a tool we're using to support our plan. So there's lots of questions about what isn't in this. And what we're trying to do is match our goals and projects that we want to expand using this opportunity for what we're allowed to use it for. So trying to match our goals with what this does. We can't make it something it isn't. It is essentially one-time funding. It lasts for 5 years, but what we're really trying to focus on: launching initiatives, scaling things up, transitioning to new models, purchasing technology and equipment, promoting collaboration, those kinds of things, so that we're not left with a lot of programs at the end that we can't keep supporting and that become part of the base. So that is sort of part of our thinking behind this. And then there are some funding limitations. So we cannot supplant the state budget. So if it's something we typically fund with our state budget, we can't use this for it. Oh, I apologize.
Go ahead. Wayne.
You're sort of hidden back here.
I don't want to stop you in mid-sentence.
That's okay.
So since it's 5 years, so you're gonna prioritize things that would build infrastructure or whatever that would.
Or transition to some new model, change things.
And just advanced technology and interoperability, some computer work and that kind of stuff to get everything up to snuff.
Exactly. Exactly.
Another question was, rural, what do you define rural as?
Yeah. So we have a little bit of work to do there. There are lots of different ways to define rural. We are clearly a rural state, although under this application, we actually were a little less rural than we might all think we are, just in terms of that definition. But there are some specific questions we're getting about providers in Chittenden County and how they fit into this. So we are working on answering those questions internally. And so I just want to acknowledge we're getting those. And I view that as on the list of things we got to sort out. That's one of them we got to sort out.
Thanks.
Yeah.
So, you have to spend $195 million by September 30th
No,
of 2027.
7.
Yes.
Yeah, so this feels like ARPA.
Yeah, yes.
So we have to spend all the money. We had a longer time frame. Well, the first batch, the CRF stuff, we had 9 months, which was insane. But so as you're rolling out a 5-year timeline, right, you have to figure out what you can actually accomplish. Or what you can spend. I guess you don't have to finish a project. You just have to spend all the money by that time.
Yes, we do also have metrics that we have to meet, and we have, so there are various obligations, I expect, but yeah, do you want to? Yeah.
Great. That's correct.
Okay.
Yeah.
And so if the focus is to try to do stuff that we can do
Yes.
after the money runs out,
Yes.
and yet we can't supplant the state budget, I'm finding it hard to connect or to cross that bridge that says, wow, if we develop all these new things, I can see technology and, I mean, we just heard from ADS this week and we know that it's kind of an open pit of money to try to get it right. So I'm having trouble connecting, not supplanting the state budget and creating new programs that are not things that we already pay for.
Yes. So I'm not sleeping much. There's a lot to figure out. There's no question about it. So I don't want to represent today that we have this all mapped out. We do have a plan. We do have a budget. We weren't sure how much money we were going to get. So there were sort of a lot of timelines to think through. And we are now working through the process of really understanding at a deep level what we can do with these dollars and how we're going to use it. Let me get to the projects because I do have projects to talk about.
Yeah.
So we hold your question, Lynn, to the project?
Yeah, I just want to say, you're talking about a transformation. Transformation is not a case of creating a new program. You're talking about changing the
That's right.
nature and the structure of the
Yes,
system.
that's right.
We work.
Similar to what I think we were trying to do last year in F-126.
Yes.
So
Yes.
that's different than saying we're going to go and plug in the things that we already do or create new.
Right, exactly. This is not backfilling old stuff.
Yeah.
That's right.
It's shifting. It's a complete shift in how we operate.
Yeah. Let me
Hopefully it's more
say,
efficient.
yes, let me say a couple more things on this slide, then I'm going to get to projects, and I think that will help. I may not satisfy you fully, but I think it will help. So we can't supplant the state budget. We generally can't fund things that are otherwise billable, although we can do, it looks like there is some nuance there where we can do some starting up of things, and we can't generally fund clinician salaries. So there's a lot we can't spend it on. I hear your concern. But there are a lot of things we can spend it on, and let me start to get to that. Let's see. There we go. Okay, so again, this is many, many projects on one slide. So there's a lot here. I like to start with workforce, even though it's not the first one on my list. I like to start with workforce because that is the one that is probably the most straightforward. And one of the things I like about spending dollars on workforce is that it actually is, if you spend money on things like tuition assistance, it is something we can turn on and off. When we take care of tuition assistance and provide people with dollars for a while, we might not be able to support a new class of students, but we can support a current class of students for several years. So it is something where, and we have, in fact, in Vermont, put different amounts of dollars toward BSAC and toward funding for workforce. So we do have, one of our projects is tuition assistance with a 5-year service in Vermont. That's required by the grant if we give those dollars out. And so that's a program that essentially creates It's essentially a forgivable loan in that the tuition assistance becomes debt if you don't fulfill your obligation. So it's not debt. It's not debt that you're bringing and we're paying it back. It's that that's the sort of the hook to meet the service requirement. So that's one that's more straightforward. We have also, we're talking about restarting the critical occupations program that was at the old Vermont Tech, now Vermont State, and that was a program that allowed for free tuition for critical occupations. So funding for nurses and at all levels. We tried to keep the application as open as we could so that we could consider med techs, pharmacy, all kinds of things that we need across our system. So that one I think is going to be the least complicated to achieve and probably where we can move money the most quickly.
Could you just help us with the acronyms because.
Oh, I
This is
apologize.
electronic health records, but then I see electronic medical records and now you have EMS and I don't,
Okay.
it's just alphabet soup.
Thank you. Sorry. I do speak really fluent healthcare and it is a problem, for sure. I'm just doing a little too long. So EHR, electronic health record.
Yeah.
Yes. EMS, emergency medical services. So EMS is ambulance service.
Okay, so it really is the EMS that we think of.
As commonly understood. Yes, it's not a spelling acronym. Yep.
Yeah.
So the tuition assistance program, would that be based, or it sounds a lot like what we've tried to do with the National Guard? By recruiting people and paying for their tuition if they promise to serve in the Guard at least part-time. Was that?
I'm not familiar with that, but we have had a VSAC has had a program for nurses for a while. So it's built on that.
Yeah, I can clarify that. We had that with the pandemic, with the ARPA money. And we had critical occupations. It was all the health occupations, it was mental health counselors, it was, I don't know, a couple others.
Yeah.
But that was all done by VSAC because it was you had free tuition. It was a free virtual loan if you did not stay in Vermont. And so that was how, and so VSAC knows how to do that.
Yes.
And so VSAC is the one that we did this when we were in Commerce as part of the ARPA money. And it has expired from what I understand now. So it is, but it was a very valuable thing to get a lot of people in who need to get to school and want to do these professions and want to go and contribute because we need those professions.
Exactly.
Real shortages. And then at that point, and continuing it this way, it's really going to be basically the same thing as we had before. It's only you're putting it under a different pot of money now.
It's a different pot of money and it's more money and also trying to expand it beyond nurses. So the VSAC program that we had was critical occupations was more expansive. The VSAC was just nursing. So we tried to leave room in the application
Well,
for
there was
more
a couple of, there was
occupations.
dental hygiene, I think.
Oh, maybe it was dental. Anyway.
We're gonna move on because we don't have.
Sorry. We went deep.
Excellent program.
Just quickly, improve transfers what?
Oh, yes. Okay. Again, this is healthcare speak. So, let me go to stronger rural health networks. So we have the blueprint for health. There's a lot to say about the blueprint for health. It is a program by which we support primary care. It's been around in Vermont a long time. It's kind of ready for some modernizing, both in terms of the payment model and in terms of just sort of how we implement it consistently. So there's quite a bit there that will allow us to build on something that we already know how to do. But I think there's room to do it in some new ways and to scale it up further. Transfers, what we mean is transfers between hospitals and other providers or hospitals and hospitals. There's a lot of, it's really hard to have good information about where services are available, where beds are available. Now, I will say, a bed is not a bed. I always say it's not the bed, it's not the pillows and blankets that make a bed in a healthcare. It is the people that make the beds. The staff is what makes a bed. But it's really hard to know sometimes where there's availability. We have people being stuck in acute settings that really don't belong there, don't need care there, taking up space in a bed that is not good for them. It's not better to stay in the hospital too long. But it can be hard to figure out where to transfer. So other states have come up with some models that seem to be helping to facilitate those transfers. So we want to use these dollars to help with that. So that's the kind of thing where if we improve the process for transfers, it would have a long-term impact.
So software and training.
It's software, it's data. Yes, it's just, yeah, exactly. EMS, so we want to enlist that workforce in a new way. So EMS is actually a healthcare workforce that isn't always working. So they might actually be able to go to a home and draw a lab in advance of a procedure rather than going to the doctor's office. That's good for the doctor's office, a little less work for them. It's good for the patient because I think we all know taking your mom to the doctor is a family project. It's a family project. So that's when my mom is not able to drive, which has happened to her a few times, and she needs to go to the doctor. It's like a whole thing. She doesn't live here. She lives somewhere else. That's true for families all over the country are experiencing that. And so the more we can bring care into people's homes, better for them, better for families, less pressure on the rest of the system. Filling out mental health urgent care, expanding complex care in nursing homes. So dialysis, vent units in nursing homes, that will definitely help with our capacity in the acute care setting where people are not able to get transferred out because there's nowhere for them to go. New mobile units for mobile health and dental. And then I do want to pause here. There is funding here for regional transformation. So this is where we're really trying to think about how to, this is the most sort of innovative and complicated. We're doing some of this as part of Act 167 and Act 68 of last year already, working with hospitals to think about what kind of care should they really be providing in their regions? Are there ways to collaborate, do it differently? We haven't really built it out to non-hospital providers. And so this would help us do more of that work to try to get more care we can get out of hospitals that if people don't need to be in the hospital, we want them to be in the lower cost setting. Again, better for them and better for the system. So really trying to work on that. We have more work to do, I think, before we have the dollars will be released for that. We got to do some more planning work around that. Yes, technology, shared electronic health records. We have some hospitals that are interested in sharing an electronic health record that will make data sharing easier for them. There are other ways to achieve that. AI transcription for small providers. And then there's also dollars here for various, for planning and for some other work. I'm going to stop there because it's just, like I said, it's hard to do 40 projects in short periods of time.
You have a sense of what projects you're going to start on first?
Yeah, we're building out sort of a 30, 60, 90-day project plan right now. I am prioritizing workforce because I think it's going to be the easiest to get out the door. So I want to get that sorted. And then there's also projects that I think may have I'm sort of trying to think about what can we do quickly, but well. And then also what is going to be complicated that we need to start right now to make sure we're doing the thinking now. So I'm sort of thinking about it in different ways.
That's short-term and long-term.
Short-term, long-term, yeah. And so we're working on that project plan and starting to look at the list of projects we've made in sort of a new way. Yeah.
And I'm not sure I got my question answered yet.
Yeah, I'm about to
collaborated with and all of that. So, okay. Did you have a question before that?
I try.
Short-term, long-term, and also the one that would give you, those that give you the biggest buck
Yes.
after it's all done.
Yes, all of those things. This is a lot. It's really a lot to think about. And so that's where we get to the public engagement piece. So we did do engagement in advance. So let me say a few things about that. When I got to the agency, I started at the agency part-time in September. In order to be engaged on this, I sort of overlapped with closing out my previous job and listening in on this so that I was ready to go roll on October, whatever it was, the middle of October when I started full-time. The secretary had already set a vision that I think made a lot of sense, which was, what do we already do that we already know about that we want to scale up? And where do we already have good input? Because we've done so much healthcare reform work already. And so there's a lot of that. We have a primary care steering committee that's meeting on a regular basis. We had multiple meetings with the Provider Healthcare Coalition Network. We have a page where people could just submit their ideas to us. So we were able to view their ideas. But we also had pretty much our workforce plan was taken from the strategic workforce plan built over the last 2 years by a workforce strategic planning committee created by this body. I don't remember when, but several years ago. So we really were trying to build on existing work in order to do this. We are now working on our next step of engagement in this time. And so I think we're going to need to do, I'm really hearing a lot of anxiety from the provider community that we're going to get out in front of them or move too fast, or they won't be able to provide input. So I'm really sensitive to that. As many of you know, I've spent the last 25 years representing providers. So I definitely hear that anxiety. So we want to give them an opportunity to hear about the project. And more importantly, we need their ideas, especially on the things that are a little more open-ended. We need other thought partners in terms of how to actually roll this out. And we can't know for them what's going to be the most useful. So there's some real work to do there. So that's part of our communication strategy for the next steps. It's part of our planning.
Okay, Lynn?
Yeah, this sounds a lot like what we do with the colleges in the past 5
Oh.
years. I mean, transformation of trans.
Yeah. Fair enough. Yeah. Mhm.
Are you planning on hiring a project manager?
Oh, yes.
We hired a project manager who took all of these disparate groups and
Yes.
gave them a chance to help formulate what we needed to do and give their ideas as to how we could do it.
Absolutely.
And actually built a way to dissipate the resistance.
Yes. So
Couldn't
absolutely.
get rid of it completely.
Would you like to hire that person?
I'm taking it. Yes, so the grant does allow us to hire some positions, and we are working on a process to get a position for a project manager in particular hired.
The speed of government has to speed up in order to make this happen. You can't have one coming on in 6 months.
Yes, that would be helpful.
That would be really helpful.
Yes.
So, I
Yes, and we have been consulting with the joint fiscal team on how to speed up that process because what we might do is do it in tranches because we are in this period where we're still in negotiation, but we have an award. We know we're getting 195 million. So we're trying to identify those critical needs right off the bat, which is certainly a project manager and at least a financial manager also.
hopefully HR will be supportive of like moving this fast. John had a question.
Good morning. So I spent a lot of time, serving as a trustee for one of our local hospitals.
Oh, okay.
I'm in tune for what we've had to do,
Mhm.
some of the transformation and anticipating this. But it also includes our EMS folks in our region because we have two, rather large-ish, services there. They have many towns. I live in one of the most rural parts of the state,
Yeah.
this kingdom. So,
Yes.
I worked as a EMT here for a chunk of time as well for one of our local services. So kind of understand how long it takes to get to certain places. But where I'm kind of going here is that I understand, so one of the pieces on this, there's some limitations which involves billable services. So our EMS
Yep.
professionals they're at various levels, and paramedics or a little bit lower here perhaps. So I assume there might be potential tuition to kind of bring them up to speed so they can do some of those things you noted here in terms of like lab kinds of things, which we'd have to just don't get too far into the weeds here. But,
Yep.
think about how to get to those places.
Yes.
Without taking like an ambulance out of service.
Yes, exactly.
Because we struggle with that.
Yes.
We have, a bunch of ambulances. We've probably collectively got 6 or 7.
Yep.
The mobile units there.
Yep.
You have to kind of just think about how to balance that all out here. I know.
Yes.
And I'm also aware here too that EMS is in the current position here of looking at regionalization. How can they better kind of leverage what they have to support each other? We do that pretty well,
Yes.
but it's not.
Yes, but is there ways?
Yes. I just think you need a project manager for that.
Yes, so EMS, of course, the health department has an EMS office, and they are going to need some help in order to really move this forward. We do have some models, a model in Brattleboro. So there are some things to look at in the state in terms of other things that we're working on. What I've learned about testifying about rural health transformation is there's always someone who knows way more about EMS than I do on the committee. So I'm not going to pretend that I know more. I don't. You know more. And there's a lot of details that we're going to need to sort out. But this is people are really especially excited about this one. Yeah. Yeah.
Thank you.
Yeah.
Just wanted to make those.
Yeah. No, great points.
Well, I'm excited that this is available to us and may help us move faster towards ends that we've been talking about. We need to go. I'm wondering, like, system-wide, are participants in the whole system, the DAs.
Yes.
The FQHCs, and all of those
All of them.
entities are going to benefit from this and be participants in it.
That is our intention, absolutely. So, so we really tried to, I actually was a little sensitive when I started in the role because we had like certain providers listed and I was like, how are we listing them? Or is there, anyway, we worked on that to either try to list them all, which is actually hard. It's easier to like, you can't believe how often you can just forget somebody. But to make sure that it was always like, and others, so that there's nothing we wrote should restrict us. And our intention is to engage with all of the providers. And I am coming from the community provider world. So I've been around a while. I've worked for hospitals and I've worked for home health. And so I'm deep in, and which is also long-term care. So I'm deep in both hospital. I've worked for insurance too. I mean, I have a lot of like sort of in my mind about community providers, hospitals, everybody's role in the system. What I always say is we really need those community providers to help us prevent hospitalizations. They're the experts. That's who we need to ask. How do we prevent hospitalizations? The people who prevent them all the time.
But I guess I was under the impression that there was some question about whether they would be eligible for.
The only question is about whether or not providers in Chittenden County in particular, that's where the question is lying. What happens to an FQHC or so we just have to sort it out because people are concerned about this. New Hampshire, we're watching what other states are doing, what New Hampshire's doing. We have a little coalition of New England states. And so we're checking with them. So that's the question and we will answer it.
Okay.
Yes.
So I'm just briefly skimming your project list and I see that Maple Mountain
Yes.
residency program, which we tried to get last year. You remember we put money in the budget and it was sort of contingent on getting global commitment. And then it was kind of said, no, we're not going to. So I'm glad to see it here, but it looks like there's also going to be general fund money that's going to be needed for that. It says the state will be contributing from its own funds to support startup.
So because of the non-supplantation
Right.
condition, we actually have to use that general fund first to do the startup. But then we would tap the RHT money to fully build out the program.
Okay, and that's not considered supplanting.
No, because it was one time in nature.
Okay, so we'll see something in the budget is my guess about that. Anyway, I'm glad to see it in here. So because we
Yes.
all need more primary care.
One of the few partners actually named this particular
Yes.
project. Sort of, because there was such strong support. And so
Dave?
Jill has to leave, but before she does, it's perhaps obvious to the committee, Vermont is really fortunate to have one of the most capable, qualified people in our little state sitting in that chair, helping to run this at this time. We're lucky.
Yeah. All right. Thank you very much.
this is a hard job, you guys. So I'm
It is a hard job.
I'm not sleeping.
Congratulations on getting
Yeah, thank
almost
you.
twice as much as you thought you were gonna get. I mean, I think everybody was kind of blown away by that. So in a world where good news is hard to find, it's great to have some good news.
Thank
So,
you.
Thanks for follow up on the Chittenden County thing.
You may follow up.
Okay, thank you, Chair. I just want to.
It's serious here. Okay.
So Chittenden County, the Chittenden County service providers serve folks from all over, right?
Yes.
So is it a priority of the administration to find ways to, what do you do? What's that? Are you, Dave? Representative Yakubani? No?
No, she'll answer, not me.
Okay. Or is it a priority of the administration to find a way to support Chittenden County providers through this? Do you know?
It is a priority of the administration to have a strong healthcare system across our state. Absolutely. Exactly whether this is our mechanism, what our mechanisms are, that I can't answer sitting here today. But absolutely, there is no part of our system that we can let go without planning, right? There may be things we don't need anymore. There may be ways we can do things differently, but we need an entire continuum of care everywhere.
Everywhere in the state.
Mm-hmm. Agreed.
Yes.
Great. I'm sure we could spend a lot, maybe we'll have you back in later when you have budget
Things are a little
information and all of that. We'll get sort of progress reports would be great because this is a really big deal.
Yeah.
So
Yes.
thank you very much.
Thank you
Good luck
so
with
much.
all the work you have to do and good luck hitting the January 30th
Thank you
deadline.
so far. 35 minutes and not 2. Whew. That's it.
Yeah.
Congratulations on that.
Thank you.
Yeah, I found a link to the list on the, right from the thing, so we can post that on our website so people can take a look at it if we want to. So committee, we're gonna take a break, a few minutes early, but we have, transportation, AOT coming in. They're gonna talk about, you may recall over the summer, the, Washington administration, canceled our EV charger thing, and then I think we've got it back, so an update on that. They want to talk about the T fund. You may recall that with the downgraded revenue for the T fund, they had to do a rescission, so the joint fiscal committee had to hear about that. So we want to get an update on what happened and did the people that had to be let go, or they landed somewhere, you know, what do they know? And they have some other things they may want to talk about as well. And finally, if you, since we have extra time, if you want to read, I forwarded you the December revenue results. Yeah. Okay, so take a look.
And
Take a look.
that's really.
And so we will go offline.